Hello, it's Rebecca here with MedSurg 1 information. Uh, week 7, we had a test and didn't have a lot of time to cover skin. So I really wanted to kind of focus in a little bit on skin disorders. That's chapter 55, I believe. Please make sure you read chapters 54, which are assessment, and chapters 56, which deal with burns. But for this mini lecture, we're going to talk about disorders of the skin. So I'm going to share this PowerPoint. You can follow along with me from the PowerPoint that's in your weekly module resources. So 54, I might have said that wrong. Chapter 54 is skin disorders. The one before is assessment and the one after is burns. So don't quote me necessarily on the numbers, just the content. So learning outcomes. We want to talk about the pathophysiology, or what's the wrong thing that's happening with each of these disease processes, the etiologies, why they happen, signs and symptoms, as well as therapeutic measures. We're going to be able to list what kind of data we collect with patients, the nursing roles, help with planning for patients, and then explain how you know if your interventions have been effective. Some concepts are going to be mobility, nutrition, and tissue integrity. So we're going to start out with pressure injuries. And we talked about this in class with our group work, working with the Braden scale. But what is a pressure injury? It's pressure against the skin. And they talk about tissue anoxia. And I want to make sure we understand what that means. So tissue, your skin, your underlying tissues underneath, and then anoxia, that's where you do not have enough oxygen. So when you are depriving your cells of oxygen, you're pushing away maybe that blood flow with that pressure. They don't get oxygen to those cells from the blood. And so then they end up having a cell injury or even death in that areas. So that can happen. That's the way it happens with pressure. It can also happen with friction, that kind of movement back and forth, and then also shear. And we talked a little bit about shearing forces of like the sliding and like the skin going one way while the muscle and everything underneath is going a different way. So what makes you more at risk? And then again, we talked about this in class: immobility. Your circulation is already impaired by maybe a cardiovascular disease. Maybe you have some sensory issues with neuropathy or something else. Elderly, they're just, by their age, they're higher risk. And then if you are either very thin or very obese, you are at more risk of having a pressure injury. So how do we prevent? So first, we want to make sure we know how to assess which patients are at risk. So using the Braden scale, like we did in class, is going to be extremely valuable because you can identify who's at risk and start doing some of these preventative techniques. So we want to make sure the skin is clean and dry. I want to emphasize the dry part because moist skin is going to lead to skin breakdown. So you really want to make sure you have that dry on there. But we don't want to be too dry, right? We also want to moisturize the skin. We want to put some lotion on the skin or some sort of barrier cream or whatever is appropriate for that patient to keep the skin moisturized. I know this time of year, my hands always get really dry and even cracked in certain areas just from that dryness. That crack, that's a portal of entry for infection that actually can cause skin to have issues. So we want to make sure we're keeping their skin moisturized as well as dry. Clean incontinence promptly. What that means is, keep them clean as possible. I love that we have external female and male catheters now. So even if somebody is incontinent, we have these catheters that are going to be kind of collecting and wicking away some of that urine from just sitting there on the skin. And we're going to use moisture barriers as needed. So some lotions and products have what's called a moisture barrier. So you put it on like a lotion, but then there's like this film that kind of dries on the skin, and it prevents that moisture from actually seeping into the skin. One thing we want to do for prevention is we don't want to massage reddened areas or bony prominences. That massage can actually injure the skin worse. So another couple things we can do for prevention, we want to have the patient shift their weight every 15 minutes. Just like we talked about in class, there can be injury that starts from pressure within 15 minutes. So like we said, we want to turn reposition every 2 hours, but we want to encourage our patients, if they can, to shift that weight every 15 minutes. Now that's not possible for all patients. So we're going to do some other things to help with that. Like if their heels are at risk, we're going to keep their heels off the bed. We might kind of elevate them on something else. We also are going to pad or protect bony prominences. Like sometimes patients will have little elbow pads or something to help protect their elbows, somewhere where we know that they're already either at risk or they've started to develop some redness, irritation. We can kind of pad those areas. We also want to use a pressure reducing mattress. And that can be either the actual bed itself has a mattress that's a low air loss bed, something like that. Or it could be, like we talked about in class, putting a waffle mattress or some sort of pad on top of the mattress to increase or decrease the amount of pressure the patient's receiving. We want to make sure we're using a lift sheet to move. When we talked about shearing forces in class, like where you have a patient who's kind of up in bed and then they kind of slide down, you can see where the skin is kind of staying this way and the body's going this way. And you can have a shear that happens. If we use a lifting sheet, we're able to kind of help move that patient off of the surface of the bed as we lift them, which helps to prevent that shear. Another really important part that a lot of your groups in class identified was providing proper nutrition and hydration. That's essential for healthy skin. And so we need to make sure we're encouraging our patients to have a healthy diet and to be hydrated. So with the Braden scale, I'm going to go over this fairly quickly. There's a few things it talks about: sensory, moisture, activity, mobility, nutrition, friction, and shear. And I'm just going to kind of go over that a little bit, or go beyond that, because we did talk about it in class. So one of the things that the National Quality Forum listed is that pressure injuries are a serious reportable event. And that means that Medicare and other private agencies are not necessarily going to pay or reimburse a hospital, a facility, wherever you're at, if a patient has these type of wounds or develops them while they're in your care. They're saying this is a preventable issue. And if you do not prevent it from happening while this patient is in your care, then you are responsible for paying for that issue. That's a big deal because pressure injuries can take a while to resolve. They can be very expensive in how they are treated. So we're most facilities are very diligent about treating pressure injuries. You're going to also know that notice this comes into play, that when you have a patient that's admitted to your area, if you're in a hospital, long-term care, wherever that might be, you're going to do a complete head-to-toe skin assessment. And if you have somebody that has any kind of skin issues, especially pressure injuries that are already on them, you are going to document them, because by documenting that the patient came in with these problems, you are then saying, listen, we get this is serious, but we did not cause this. That documentation allows the Medicare or other private insurances to then pay you for your care that you gave that patient. I say pay you, it's pay your company. But the better your company is doing wherever you're working, the more dollars they save, I say the more dollars that goes in your pocket as well, because they're more likely to have raises or other compensation for their staff. Okay, moving on. So signs and symptoms of pressure injuries. Well, first of all, there's probably going to be pain, unless we're looking at like a neuropathy in the foot or somewhere else. You're probably going to have an open ulcerated area, depending on the stage. And then there's going to be some colors that are involved. Black usually means necrosis, and we have some pictures I'm going to show later. Yellow usually means infection, perhaps slough. And then red usually means healing, which is nice. So how do we diagnose these, right? So typically we're going to do a physical examination. Anytime we have open areas of skin, we're going to want to get a culture and sensitivity and send that to the lab. Now, that's not something as nurses we can order, but we can ask our providers for that order, because we know that if that open area is infected, we want to treat it right away, and we want to treat it with an appropriate antibiotic. We probably want to do some blood supply studies depending on where it's at, meaning like a vascular study. If somebody has a wound on their foot, they might do some vascular studies to see how much blood is actually flowing through to that foot. And we also might do biopsies of that area. So therapeutic measures, we already talked about what we can do to prevent the pressure. There might be some debridement. So any of that dead or infected tissue, we want to get that out so then we can promote the proper wound healing. So that debridement, which means, well, a few things. It's going to be removing the bad tissue, right? So mechanical, that means usually a provider, a doctor, nurse practitioner, surgeon, they go in and scrape off all of that infected or dead tissue. You also have some enzymes, creams, ointments, bandages that can go in the wound and debride with their enzymes that are there, and you just kind of clean it out afterwards. You also want to make sure that we are cleansing. And it says, I love that it says 4 to 15 PSI. And that has to do with the pressure per square inch. Yeah, PSI is pressure. Oh, it even says it right there. Pressure per square inch. You are not going to know what your pressure is if you have a syringe or you're irrigating. What I do want you to know is that when you are irrigating, you are not blasting that wound with whatever you're irrigating it with, saline, sterile water, whatever it may be. A few reasons. You don't want to cause more pain, right? A lot of high pressure is going to cause pain. You don't want to cause more injury to that area. You want to make sure we're not debriding some of that maybe good tissue that's there. And you don't want things squirting back up in your face, right? You're going to be wearing hopefully proper protective equipment. If you're debriding anything or you're cleansing or irrigating, you should be wearing a mask and face shield because you don't want to get anything in your face. But just know, I'm not going to ask you about PSI, but you are just know to be gentle with your irrigation. So different types of dressing. I'm not going to go through all of these. Just know there are a lot of different types of dressings. How do you know what to use? Honestly, usually there is a wound care nurse that will let you know exactly what it is. If the wound is dry, you want to add moisture. And if the wound is very wet, you want to wick out that moisture. So based on what kind of wound it is, that's how you know what kind of dressing you're going to be using. There's also negative pressure wound therapy. And I like how this kind of shows you these pictures here. I wonder if I can move this little bar down. Oh, I can't. Good. I don't know if you guys could see that, but that was bothering me. So a negative wound pressure, negative wound therapy, or a wound vac, often it's called. It's to a usually rather large wound that's open and deep that has a lot of drainage coming from it. And so it is a self-contained system where you can kind of see this picture of this person's wound. And it has this black material is actually a foam, essentially, that fills up that open wound space. And you put a dressing over it. And when you attach this tube to the vacuum and activate the vacuum, that gauze or foam compresses down and it sucks any extra fluid, exudate, anything from that wound. It's very gentle negative pressure. And these can be very effective at helping patients' wound to heal. I think you'll learn some about this in foundations when you do your wound care. Okay, so moving on, stages of pressure injuries. Again, we talked about this in class, so I'm not going to spend a lot of time on it. Stage 1, the skin is intact. It's red and it does not blanch. What does blanching mean? Press down on anywhere on your skin. Should be like press down. I don't know if you can see it. It's pink and I press down, it's white, but it's turning back pink. That's blanchable. You can push out the blood flow essentially, but it does return. Stage 1, it's red, but if you push on it and then let go, there's no white spot or lighter colored spot. It just stays red or darkened. And again, I just want to make sure you guys know when I say red, that doesn't mean it's going to look the same to everybody depending on their skin color, right? My skin is pretty pale. You're going to be able to see a reddened area on my skin pretty well. If somebody that has pretty dark colored skin, it might look not necessarily red, it might look more purple, or it might just look like a darker shade of their skin tone. So you want to compare that to whatever their wound or whatever you're concerned with, compare it to their other natural skin tone to be able to really assess it properly. A lot of textbooks and a lot of our information talks about red skin. That's very Anglo-American and doesn't address people of color. So I just want to make sure you guys know if you have somebody, their skin is not pale white like me, you might not see that bright red. Look at their other skin tone, and it's going to be usually a darker color. Okay, moving on. Stage 2. Partial thickness skin loss. So that skin is not intact. There is a removal of that first layer of skin, and you can see the dermis underneath. Stage 3 is full thickness, so all the way through that skin. They may have eschar, so that's that black dead tissue there. Stage 4 is full thickness loss. You can actually see the muscle, the bone, tendons, things like that. So there's also non-stageable, which means you've got eschar, which is that black, thick, dead tissue. And you can see it's on there. You know there's a problem, but you don't know how deep that problem goes. So that's unstageable. You also have a deep tissue injury, and that's where you have that non-blanchable. So like we talked about, stage 1 is not blanchable. Non-blanchable is even darker. It's gone beyond that red or kind of darker color to a deep maroon, purple, black, something where you can tell it's very different than just a reddening or darkening of that normal skin color. So here's some of the pictures where we have, and I love that they give us real bottoms or wounds to look at. And this is very common to see stage 1. So you can see the skin is intact, but it's reddened. If we were to push on this area, it would stay red. It would not blanch. Here we have stage 2 where the skin is lost, but we still have the dermis underneath there. Here, stage 3, all right, we've lost that dermis. See how you can tell there's a difference between just the top of the skin and then down into the dermis. Oop. And then we have stage 4, and that's where you can see there's probably bone, muscle. That red is probably muscle underneath there. All right, here is this unstageable and deep tissue. So here, see how this unstageable, that looks gnarly, right? It looks pretty bad, but we don't know how deep it goes, so we can't stage it. That doesn't mean they leave it like that. Somebody with an unstageable wound is probably going to be going into surgery, having a wound consult to come debride it. They're gonna figure out how deep it goes, and they're gonna fix it. It's just on first glance, when we're first looking at it, we can't stage it because we just don't know. And then over here, we have this deep tissue injury. So you can see how this area around is reddened, but then you have this deep purpley, like almost black in some areas area. And that's where it's that deep tissue, like the muscle, the deep muscle under there has been damaged. All right, so when we talk about nursing diagnoses, different than medical diagnoses, we're going to have impaired skin integrity, risk for infection, acute pain. Those are all very appropriate nursing diagnoses for patients with pressure injuries. Okay, moving beyond pressure injuries, we're going to talk about dermatitis. All right, let's word build for a minute. Derm, what does that mean, right? Oh, you're not here to answer. Derm is skin, right? Like dermatomes or epidermis, like that's skin. And then itis is inflammation. So dermatitis is inflammation of the skin. Oh, look, it even says it right there. So etiology, where does it come from? Well, you can have things like allergens, something that somebody's allergic to, irritants, it could be hereditary, or even stress. So there's a couple different types. Contact, and that's where you actually make contact with the irritant. I am really sensitive to grass. I know it's weird, but if I would go roll around in a field of grass, especially that just got cut, my whole skin would break out. One second here. Okay, sorry about that. Somebody was knocking on my door. Okay. I think I was telling you that I would be. There we go. Okay. I think I was telling you guys how if I rolled on grass, I would get completely covered with hives, and that's from contact dermatitis. Oh, goodness. Now I've got to go all the way back to where I was. Okay. And then there is seborrheic, and that's a chronic inflammatory where you are producing a lot of sebaceous, or some of the glands in your skin, you're producing a lot of secretions. Here's some different types of dermatitis. You can see how there's a lot of inflammation, redness, bumpiness. It's probably pretty itchy. So signs and symptoms: rash, itchy. You might have lesions, scales, crushed, fissures, all of these. I'm not going to go over those in depth, but just look through your book and read those. So what are some complications? Well, anytime we have irritation to the skin, it could lead to an opening on our skin, which would be a portal of entry, right? Like infection. So complications could be infection, which could lead to sepsis, that systemic infection. How are we diagnosing this? What do we do? Well, we're going to get a history physical. We're going to find out, are there things that they already know they're allergic to, or what were they exposed to? What have you done the last few days? What have you been eating? Have you had new laundry detergent? What in your environment has maybe changed that they've had this reaction? If they have an open area, there's a weeping area, we might get culture and sensitivity. And they might do, I honestly don't remember what teledermatology is, so I don't know. I'm not going to test you on it, but you feel free to look it up. So therapeutic interventions. You're probably going to give some antihistamines. So that would be things like Benadryl is a very common antihistamine that is given, or diphenhydramine is the other name for it. Antihistamines can often cause some sedation. And so you want to make sure we're monitoring for that, or let patients know if they're going to go take some antihistamines for their allergy or skin reaction, they might not want to go drive because they might be sleepy. Depending if it's painful, they might get some analgesics or pain medication. Antipyretic is an anti-itching medication. Depending on the severity, they might be prescribed some steroids for the inflammation. Now, it might be a just topical steroid cream that's in a localized area. If it's a pretty intense skin dermatitis, they might actually have oral steroids that are going to be systemic. Sometimes an oatmeal bath can help with that. It is very calming to the skin. And depending on the type of irritation, some wet dressings cooling on the skin can be helpful. Some nursing diagnosis: impaired skin integrity, disturbed body image, knowledge deficit. All right, next skin disorder: psoriasis. I know there's a P on here, but you don't, it's a silent P. So it is pronounced psoriasis. So psoriasis, it's an inflammatory disorder. It's where you have a proliferation, I can't say that word very well, where essentially your epidermis cells on your skin, they grow too much and they produce these scales on your skin. Usually patients who have psoriasis notice that they'll have flare-ups, or it gets worse when they're stressed, when they have the weather changes, like it's cold, or their hormones are changing. Maybe it's a woman during her menstrual cycle or during puberty. Those are all things that can affect psoriasis. You can see here on this picture, these are where these scales that have kind of developed on the skin, and those are from psoriasis. Some of the complications could be infection, right? Those scales could open up and become infected. Somebody with psoriasis is going to be more likely to develop arthritis. They might have some nail bed changes as well. So they're going to do a physical assessment. They're going to rule out that this isn't an infection on their skin. There's not like a fungal infection that might look similar. They might even do a biopsy of that skin to make sure there's no other disorder happening. And then what are we going to do to help treat the psoriasis? Well, giving baths, excuse me, in a bathtub, especially with those oatmeal baths can help. They might do steroids, salicylic acid, vitamin D creams, those can all help. There have been some studies that have showed UV light can actually help with psoriasis. When it's significant enough, sometimes even lower doses of chemotherapy. Okay, moving on. Herpes simplex virus. So that is a viral infection. When we talk about herpes simplex, 1 is above the waist. 2 is below the waist. So when somebody, maybe you have a patient that has herpes infection, it's going to be important that you know, is it 1 or 2? Because 1, you're going to be looking up here. 2, you're going to be looking down there. It's a primary infection, meaning it's from either a direct contact with somebody else. Maybe there was a respiratory droplet that got on you, or a fluid exposure. It can often, once you are exposed and have been infected with herpes, it's going to lie dormant in your body, but it can flare up, and you can have a reoccurrence of it with stress, with sickness, hormonal changes. All of those things can cause it to flare up. So usually you're going to have some, you have this burning and tingling in the area. And then you're going to have these pustules or vesicles that form, and they're going to be painful and itchy and burning, and they're contagious at that point. When they start to scab over, those pustules, they're not leaking any fluid, they're scabbed over, then they are not contagious anymore. But while they are open and leaking fluid, they are contagious. So we want to make sure we're doing a good history and physical. If that area is open and there's leaking fluid, we're going to get a culture from it. We're going to give them some antiviral agents, either oral, meaning that pill that will work in their whole system, or we might just do them topically to one area. If maybe their skin got infected and there's a bacterial infection now from that, they might give them antibiotics. And we want to teach them how to try to avoid certain triggers. You know, what can they do to help prevent them from the herpes from flaring up again? So then there's herpes zoster. So that's different. Remember, we were just talking about herpes simplex. Now we're going to talk about herpes zoster. And that is also called shingles. And you can see kind of what it looks like here. They're these kind of blistery vesicles is what they're called. And they are, when you have an inflammation of it, an infection, you have these vesicles that form. It follows a nerve distribution. And I think there's a picture, and it's usually one-sided, one side of your body. Oh, they don't have it on here. Huh, I thought they'd have a picture of it. Usually you can see, they call them dermatomes of certain areas of your body. And usually if you have like a herpes zoster or shingles, it's only going to be localized in like specific areas of your body. It's not going to be like all over the whole trunk. It's going to be only, you know, right here in this side of my body in this area. It's a reactivation of varicella zoster virus, which is chickenpox. So if you've had chickenpox, then you can develop herpes zoster as well. It can occur with reduced immune function. Elderly people that have immunocompromised, like AIDS, or I think I told you guys my mom had a liver transplant. So she takes medication to depress her immune system so she doesn't reject her transplanted organ. The first year after her transplant, she developed a really bad case of shingles because she was so immunocompromised that herpes zoster was like, hey, I'll take advantage of that. And so she was treated, but that was pretty irritating for her. So if somebody has an active infection, we want to avoid that. There's actually vaccines that they can take for that to help prevent. And then signs and symptoms, I mean, similar to some of these other skin irritations where you have these vesicles, it's irritated, it's itching, it's painful a lot of the time. They also can exhibit some fever and malaise, which is like exhaustion or just being very tired. And that's because their immune system is working overtime fighting this infection. Complications, they can have some neuralgia or nerve issues after this. They can have persistent pain that just continues on for a while. Sometimes with that pain, there can be hyperesthesia, which means they feel things extra. Like if I were to touch my hand, I would feel it. If I had herpes infecting this area, I might touch it and oh my gosh, I'd really feel it. Like it's just like extra feeling. You can have ophthalmic herpes zoster, so in your eyes, and that's very dangerous. That can actually cause to blindness. And then it also could lead to sepsis, a systemic infection. They're going to get, again, history and physical. Has this person had chicken pox? Have they been, immunized? They might get a culture. Again, they're going to be given some antivirals like acyclovir, probably some analgesics, anticonvulsants or antidepressants. Sometimes that can help with some of the nerve issues. Antihistamines like Benadryl help with the itching, the steroids. I'm going to skip over the cue recognition, but if you want, you can pause and read over this. And then here's an answer you can read over. And then again, with the S-bar handoff, I'm going to you can pause it to read it, and then you can practice it pausing through the suggested answers. Okay, fungal infections, so fun. So we talked a little bit, I don't remember which lesson it was, about bacterial infections and then fungal infections. So usually it's from a direct contact with a fungus of some sort, or you have an overgrowth of bacteria in your body. Fungal infections usually need a warm and moist environment. And so if you think of common areas for fungal infections are usually the groin, your toes, under your armpits sometimes. Those are areas that are usually pretty warm and pretty moist. And that is an area that fungal infections love to grow in. So you can have different types. Oh, look, they even have, so tinea pedis, which is athlete's foot, tinea capitis on the head, and then tinea corporis on the leg there. I'm not going to test you on the different types, just know there are different types based on where they're at. Here's one on the groin, and see how this is like this big wide lesion here compared to some of these smaller lesions. Fungal infections usually have these like kind of rounded irregular borders. And then there's also thrush or candiditis. And so you can see these white, they call them papules, marks on the mouth, and that's a fungal overgrowth in the mouth. Next skin issue, cellulitis. So cellulitis is an infection of the skin or the area around it. It's inflammatory. It's usually caused by staph or streptococcus. A lot of times you'll see the MRSA, like methicillin-resistant staphylococcus. Usually it's from an open wound or trauma. Sometimes it's from maybe a bug bite that got infected. Sometimes we just don't know why the skin area got infected. We don't see an open area, but there's clearly an infection happening. So signs and symptoms, there's going to be warmth. It's going to feel warmer than the rest of the body. It's usually red, swollen, painful. A lot of times these patients can have fevers. Their lymph nodes can be enlarged. We're definitely going to get a culture and sensitivity if it's open and draining. We're going to get blood cultures. They're going to be on antibiotics. A lot of times we're going to put maybe a topical antibiotic on it, but if it's pretty significant, they're going to be on either oral antibiotics, or if the infection is severe enough, they're going to be on IV antibiotics as well. They might need to have a debridement, which is similar to the pressure injury when we talked about with eschar or other things there. We might need to go in and clean out the dead or infected or infection and then let the good tissue heal. We might want to elevate that extremity, or if it's on an extremity, we would want to elevate that area. We want to monitor for sepsis. The cellulitis can be pretty bad, and if it goes systemic, those patients can get sick very fast. You also want to measure the area. I want you to think for a minute of how you would measure an area of infection for cellulitis. Okay, hopefully you thought about it. What about if on my arm? We talked about those signs and symptoms. It was red, it was swollen. How do I measure that? Well, typically what we would do is actually measure it. We would mark out, a lot of times we'll get a marker and we'll draw the borders of the area that is red, swollen, infected. And then if it's getting worse, that redness is going to extend beyond those borders and we're going to see that it's growing. We might also see that it's shrinking if it's getting better. If it's something like my arm or leg, we might take the circumference and measure around to see if it's getting bigger or smaller. Insert figure. I don't know what this is about. Okay. Acne vulgaris. That's another skin disorder. So acne, an infection. So increased sebum, which is is produced in your skin, and it obstructs those little ducts out to your skin, and it can cause infection. So you can have either open or closed acne areas, and they're going to be there's a lot of different treatments for this. Sometimes peroxides or vitamin A acid, yeah. You might also have antibiotics or other medicines like Accutane or hormone therapy to help with this. They're going to have risk for infection and pain. Ooh, moving right along. Pediculosis. So this is irritation from an infestation by lice. So you're not going to get this unless you have lice. It's called different names based on where your lice infection is at, right? So if it's on your head, on your body, in your pubic area, it'll be called different things. You're going to have itching or rash, and then you're also going to have lice or nits or something where you can see like, oh yeah, this is a lice infection. We want to get an history and physical. H&P is what we call history and physical. And we want to see like, have they been exposed to somebody with lice? Do we actually find lice on them? If they have lice infestation in their pubic area or pediculosis pubis, we also want to check for an STI or sexually transmitted infection, because usually it's transmitted sexually if it's in the pubic area, and which makes them more at risk of having an STI. What do we want to do? Well, we want to get rid of the lice, right? So we're going to use something like Nix, Prethorin. We're going to be helping them either brush it out or get rid of it. And there's also other medications that can help to kill the lice or the eggs. Mechanical removal is using those little lice brushes to get rid of the eggs, get rid of the nits, things like that. Antipyretics, those are anti-itching medicines, and then topical corticosteroids. So the steroid is going to help with inflammation. Patient education. Lice can be very transmissible and it can be difficult to contain. So I want to teach the patients about, hey, this is how you medicate for this. This is what you do. This is how you need to clean your clothing or your bedding, or if it's kids, how to clean their toys afterwards. Because it is so transmittable, we want to also show them how to check their friends or family, loved ones, to see if they have also got lice, because it's one thing if we treat our patients for lice, and then if we send them back to their families who have lice, they're going to get it again. So we want to really do some kind of community health teaching. Scabies, again, something else that's living on your skin. These actually burrow into and underneath the skin tissue. It's usually directly from contact with infected clothing or animals. Here you can kind of see the signs of it, this irritated redness to the skin. They might shave off part of that lesion and send it to the lab to test for it. And then to treat it, they're going to give some scabicides, which is kind of a fun word. Elamite or Cortran are two examples of that. They also are probably going to give some antipyretics, which are the anti-itching medication, again, because it's itchy. Again, we want to do patient education, right? How do you treat this? Warm soapy baths can be very comforting for them. We also want to make sure, hey, if you have it, do your family members have it? Do they know what to look for? Are they seeking care? How do you wash your clothes and linens to help prevent from spreading it or getting it again? With scabies, it's tough because these patients, when you have those lesions, they can be itchy for up to 2 weeks, even after they've been treated. So it can be pretty miserable. Okay, Next topic, malignant skin lesions. So malignant is regarding like cancer is another way of saying that. So it's a cancerous skin lesion. So it can be cancer coming from the basal cell layers, the epidermis, or the melanocytes. So here you can see a picture of basal cell carcinoma. That's on somebody's forehead. Here's squamous cell. Here's a malignant melanoma. I think that's a toe in between there. I'm not really sure what we're looking at. Risk factors. So ultraviolet rays. So people who are out in the sun a lot, or people who have used tanning beds a lot. It's not necessarily popular now. When I was younger, it was very in vogue to be very tan from a tanning bed if you had light skin like me. And those people are actually a lot higher risk of having skin cancer. If you have fair skin, that does put you more at risk of developing a skin cancer. Some people are more genetically predisposed to having skin cancer. Just like your family might have a lot of high blood pressure, some families might have higher incidences of skin cancer. Certain chemicals or immunosuppressants might also just make you more at risk. So how do you prevent it? Right? That's what we really want to talk about. How do we prevent this from happening for our patients? So limit your sun exposure. Maybe don't tan in a tanning bed. Use sunscreen when you're out or wear protective clothing. We also, with that prevention, we want people to look at their skin. If you have moles or odd looking skin areas, especially if they're changing color, they're changing the shape, anything like that, you want to get those looked at by a dermatologist. When you go into a dermatologist, they're going to do an examination and even a biopsy. I had a little thing on my nose a couple years ago, and my doc wasn't sure about what it would be. And so he biopsied and took it out, and I had this big incision on my nose for a while. Anyway, it was fine. So they're going to be taking it out. They might do chemo and radiation. Oh, mine wasn't cancerous. I don't think I said that. Mine was non-cancerous. It was like a mole or something that was just growing weird, but I got it checked out. They might do oh, this is dermatological surgery. I'm going to kind of brush over this. Okay, here's some review questions. I'm not going to go through them. I'm just going to scroll through. So just pause the question and then pause on the answer. Okay, hopefully that was helpful. And I look forward to see you guys in class next week.